Just want to welcome you all to this session. My name is Chang. I'm an emergency physician at Columbia University, and it's a great pleasure to really introduce to you our panel of experts here. I think we've got a great session for you guys. What's going to happen is we're going to introduce a topic of great fear for many providers in the emergency department, namely ischemic stroke and a pregnant patient. I mean, I think this is something that, at least for me, gets me pretty nervous. There's a lot of questions about management strategies and treatment approaches, and I'm hopeful that by the end of this session you'll be able to get some good pearls to walk away with to your emergency departments. The way the structure for this session will be is we're going to give you a broad overview, some basic statistics, some basic numbers, and then we're going to segue into an actual real case. We actually, through a very fortunate and very generous individual, a former patient who's actually had an ischemic stroke will share with us some of her comments on the experience. And then from there we'll segue into an actual case, a real case that's been generously provided to us by Dr. Barth. And in that case we're going to have a few questions that I'm going to basically talk with the panel. And so the way the format of this session will work is I'm going to kind of have some questions for the group, that expert panel. They'll kind of brainstorm some ideas that I'll share with the audience. And then we're going to leave about 10 minutes for you guys, just the whole audience, open up to questions. So if anyone has any burning questions or anything like that, you can feel free to ask at the end of the session. But for the sake of time, since we have a pretty short amount of time, we just kind of want to be kind of quick and efficient with the session. Just quickly, I wanted to introduce our panel. So we have Dr. Joe Miller from Detroit receiving Henry Ford. Dr. Eliza Miller, who is at Columbia University, is actually a stroke neurologist. Tracy Madsen at Brown University, and Bradley Barth at University of Kansas. We have no disclosures and no conflicts of interest. Okay.
So I'll briefly talk about, the epidemiology is, well, let me ask you all, how many of you have seen a pregnant woman or a woman in peripartum area with a stroke in the last year or so? So a couple of you. Yeah. So it's certainly out there, but when you look at it, overall, out of 100,000 deliveries, it's actually very few patients have this complication. And then most of them end up being in the postpartum period, with some antepartum, and I think often some of the complexity is really in the period most proximate to delivery or before delivery. And so a lot of the case we talk about, we'll go through that. So we're fortunate, unfortunately, one of my cousins who lives in northern Indiana had a stroke after her first pregnancy. And so she was very kind she couldn't come down this week, but she was kind enough to make a short video to kind of tell us what her experience was like. And so we'll go through that right now.
Press it one more time. Oops. Yeah, I see the volume up. 1 second. Yeah. Giovanni, is there any way to get the volume up? Oh, he left? Oh.
Yeah, it's this thing.
All right. I think we're on it. Like true emergency physicians, you got to troubleshoot in a moment. No. Let's see.
I went into. Hi, my name is Alicia. I'm a nurse on a medical surgical unit at Memorial Hospital, and basically to talk about what happened with my stroke, I was 3 months and 1 day postpartum. It was June 18th, 2013. The pregnancy was totally fine. I had absolutely no complications. My doctor's visits were about 2 minutes long, and I went into just natural labor, exactly 39 weeks. Everything was completely fine, did an epidural vaginal delivery, everything went totally smoothly. Came home a couple days later, and the whole postpartum was perfectly fine. I had absolutely no issues, and it actually happened in two separate incidences. One was at 6:30 in the morning. I woke up with a weird tingling, burning in my nose, and a slamming headache, sudden nausea. Got up to go to the bathroom and kind of fell into the wall. Just had absolutely no balance or coordination on my right side. Just vomited and had a massive headache for about 20 minutes, and the thought of a stroke crossed my mind at that point. But I did the facial test. I had no facial droop. I had no slurred speech. I did my whole arm test. I had no lag, and I just thought it was a weird postpartum migraine starting off. So I took a couple Tylenol, went back to bed, and just kind of slept off the headache for a few hours. Woke up, felt pretty fine, did some yard work, some cleaning, hung out with my kids, and then at about 3 o'clock in the afternoon, I got in the car to go to get a haircut, and just as I was pulling out of the driveway, I had that burning, tingling sensation in my nose start up again, immediate headache, nausea, so I obviously parked the car and barely made it across my lawn to the front door. I was just totally stumbling. My right side was completely just dropped. At that point, I didn't have any slurred speech. It was kind of weird. The ER staff didn't really know whether or not to call it a code stroke. They gave me some Zofran for the nausea, which worked awesome. They went through some questions, and then they did a CT to see if there was a hemorrhage, and the CT came back negative. So back in the ER bay, and then they decided to run a CTA. So I went for the CTA, and that's when they found that I had a left vertebral artery dissection with a clot. So they started me on heparin. I have no idea what time or how long any of this took. Recovery has gone pretty well. The first few months really kind of sucked. To be honest, being on Coumadin was awful. I felt just completely messed up, and I was worried that that's how I was going to feel forever. But after a few months of being on Coumadin, I went back for a repeat CTA at the end of September, and they found that it had healed. So I just went on daily aspirin, so I do 81 milligrams just a daily aspirin. Took about a month for me to be able to swallow properly and eat a meal. It really took a lot of speech therapy help. I couldn't chew and talk. I had to do chin tucks to swallow, so that was probably the hardest part coming back.
Well, thanks again to your cousin for sharing this. So this is actually an actual case that we're going to be presenting to you guys. We've obviously changed some of the details of the case so that this will respect privacy, but these are actual cases. This is an actual individual that was managed in an emergency department. This case is a 30-year-old woman, 9 weeks pregnant with twins, coming into the emergency department with aphasia and right-sided weakness. You can see on the HPI, it started about 2 hours prior to arrival. No known history of these symptoms. Her pregnancy is known as she's had a positive IUP, 9 weeks, 4 previous pregnancies, uncomplicated, and 1 miscarriage. Medical history is just remarkable for some hypothyroidism, and is just on prenatal vitamins and no allergies. This is a big, busy slide, but it contains most of the information on her physical exam. You can see that she's normotensive. Heart, lungs, abdominal, extremities, and skin were all within normal limits. On her neurologic exam, obviously difficult to assess secondary to her inability to speak. However, cranial nerves at 2 and 12 were intact. With the left facial droop, pupils were equal round reactive to light. And if you look at her motor exam, she had 2 out of 5 strength on her right lower extremity and 5 out of 5 strength on the left. So at this point, maybe the first question to the group is, you know, ischemic stroke is pretty rare in this age population. What are other things that you think about kind of in approaching your differential to managing ischemic stroke, and are there other things that kind of clue you into saying this is something more likely X versus Y?
You know, the first thing that I hope is that it's something else. than that I can prove that it's not a stroke. That's my big fear. Things that, I'm going through my mind is this a migraine? Particularly if it's a complicated migraine. I like to hear that they had a history of this, and this has happened 3 times before, and every time they got better. But that doesn't completely rule it out, but that does make me feel better. Other things are there are other stroke mimics, metabolic disorders or infections. In young women, I'll also, if there's MS stuff, that crosses my mind. Seizures are another nice thing. And if they're young enough to have a first-time seizure, then maybe this is a postictal state. Those are things that I like to think about and hope to find, but...
You're never too old to have a first-time seizure.
Well, that's true. That's true. They just get worse as you get older.
Yeah, that's a good point. So you can see it's a very broad differential kind of approaching this. I mean, in this case, it's a little bit more pretty severe, so I think that the emergency providers in this situation kind of quickly honed in on kind of like concern for a possible ischemic versus hemorrhagic stroke. So the next step from there was kind of like the workup. So you're going to be getting blood work, obviously, but really kind of one of the big questions I think a lot of us as emergency providers are thinking is imaging. We're scared. Both the patient is worried about potential radiation risk to their unborn baby, radiation risks to themselves, and the big question is, how do you approach imaging strategies for someone with a suspected stroke in an individual who's pregnant?
Turn it on.
Is this working? Yeah. Okay. Well, I would answer that you should approach it exactly the same way you would approach it in anyone else. And what I usually, so this is also the position of the American Radiological Society, or that the amount of radiation in a non-contrast head CT is so small. It's actually, what I tell patients, it's less than the amount of radiation you get flying across the country. So it's orders of magnitude less than what would be even remotely harmful. Mm-hmm. So you shouldn't even think twice about it. They say, oh, shield the abdomen. That's maybe just to make everybody feel better, but it's really fine. And then in terms of the contrast, whether you can get a CT angiogram, you can. And in that one, I think that you might want to hold off in a situation where the benefit doesn't clearly outweigh the risk. The risk is very, very slight. Again, the radiation is really tiny, tiny amount. There is this sort of theoretical risk of neonatal hypothyroidism, which is like from some animal studies. So they recommend that the baby be tested when they're born for thyroid, but that's actually not ever been an issue that's come up. And so in this situation where the woman has a large vessel syndrome, with a high stroke scale, there's no question that you should get a CT angiogram to look for that, because it's obviously going to change your management significantly. And so don't wait for the MRI, because that's just going to waste time.
Okay, and if for example, your institution does have like a really quick MRI turnaround time, are you getting an MRI like with gadolinium, without gadolinium? I mean, what's the approach that you would do for an individual like this?
So gadolinium is actually contraindicated during pregnancy. There is some risk involved with that, and also there's no reason you would ever need gadolinium for a stroke. It's not an absolute contraindication, so like we've taken care of patients that had brain tumors, for example, when they were pregnant, and they really, really have to have the contrast, and then it's a risk that you can take, but certainly not for stroke.
Any thoughts about, so this case was clearly a large vessel stroke, but any thoughts about someone with a smaller stroke syndrome and thinking about CTA versus no CTA?
Well, I don't always just automatically get a CTA. So you don't need a CTA for a TPA decision. All you need is the non-contrast. And if it's a small vessel kind of syndrome, with a low stroke scale where the person, or if you think the person's not a thrombectomy candidate, she obviously would be, but for some reason, like if their modified Rankin is too high to start with, or if the stroke scale's 2 and it's not really disabling, there's no reason to get a CTA. So I wouldn't in that case.
Thank you. I think the other point to consider is depending on where you're working, when you're ordering scans in pregnant patients, and I know I've run into this in my shop, you can run into a decent amount of pushback. So even though we know that the risk of getting a non-contrast CT scan in this patient is much, much lower than the benefit, you definitely can run into some pushback either from staff or nursing or techs or whoever it may be. But really, as a team leader in the emergency department, making sure that you're advocating for your patient and explaining to the team why you're doing what you're doing. And I know that the other issue is that can delay imaging in many emergency departments because you're signing forms and having long conversations about it, and we really have to kind of push past that in a time-sensitive diagnosis like this.
And another thing to keep in mind is that, sometimes people say, oh, we have the MRI. This is, at my institution, you definitely can't get the stat MRI. But at some you can. But you should remember that actually about half of pregnancy-related strokes are hemorrhagic. And so then, you really are wasting a lot of time to get that MRI. So you just get the CT.
One more thing relevant to the imaging. So, potentially, say this patient had come in 6 hours into her symptoms, and so you're trying to, and say she, say you're wondering whether you're going to need to do CT perfusion imaging to decide about thrombectomy. Is this someone you would do the CT angiography, confirm that there's a large vessel, and then proceed to CT perfusion, or would you potentially do the perfusion before, at the same time you do the CT angiography?
That's a good question.
If they're out of the traditional window, then I would go straight to the perfusion imaging. If you have that, it depends how
your systems are set up.
Systems are set up. We actually don't have that software yet, so I would take that patient to the MRI, and that's the one that you make them take. But yeah, again, you have to go by what the trials did.
Yeah, I don't think. We've only had CT perfusion routine imaging at our institution for a few months now, but in our protocol, we would potentially confirm a large vessel occlusion on CT angiography and then make a call. But I've certainly seen many institutions where they're just doing the CT perfusion on anyone with potential large vessel and then. So.
Yeah, I think that's how we would do it. Is CTP first.
Yeah.
And I'm sorry, just more like just really basic questions because we have a really wide audience too. So I know people know about giving TPA and stuff, but why are we focused on large vessel occlusions or other treatments for strokes and things?
Yeah, so just to back up a little bit, part of the reason we're talking about perfusion imaging and decisions on the large vessels because of multiple large trials, and including ones very recently, have showed that if patients do have a large vessel occlusion, that they should go to embolectomy for a number needed to treat of only about 5 patients, and sometimes less depending on the trial. 2 patients depending on the trial, right? Number needed to treat 2 to lead to great outcomes. And then very recently, this past February, were trials showing that you can extend that window as long as 24 hours from the onset of symptoms.
That's what I was talking about.
Yeah.
Great, thanks. So the lab work, just moving along. Lab work, nothing really stood out. Finger 69. This is the initial non-contrast head CT. So the official radiographic read was question very subtle areal hypodensity around the anterior aspect of the Cillian fissure, which may be consistent with some ischemic change. Otherwise, unremarkable, no hemorrhage or other intracranial process. So now, if you imagine yourself, you're in the emergency department, you've seen this patient, you have this imaging now. Now the big question is, to lyse or not to lyse, right? Are you going to give this person TPA or not TPA? Or some of the other strategies that Dr. Miller just kind of mentioned. So how do we approach this in terms of giving management strategies to these patients that we now have a pretty high suspicion for an ischemic stroke that seems within a therapeutic window?
Do you want to take a vote first?
Yeah, that's a great idea.
That's a great point, Dr. Barth. So how many, you guys can close your eyes, how many of you guys would give TPA to this patient? Okay, and how many of you guys would not? All right.
And who would have a big discussion with the patient about doing it? All right.
For the family.
Yeah, right. She can't say anything. Yeah.
Yeah.
Well, that was part of the problem too.
Yeah.
So I think that, I mean, there's no clear answer here, and the answer is probably somewhere in between those options. Unfortunately, as we know, pregnant patients, we have very little data on how pregnant patients do after getting TPA. Clearly, no pregnant patients were enrolled in the 1995 NINDS trial for TPA efficacy. So we really don't know a lot. We have some more recent data from Get With The Guidelines, the national registry, looking at over a long period of time pregnant patients who got TPA and comparing them to non-pregnant patients. The study included, I think, just under 40 people, so it's obviously a very small number. Fortunately, the patients that got TPA did have similarly favorable outcomes compared to the non-pregnant patients. There was a slight increase in symptomatic intracranial hemorrhage, no increase in mortality. Similar numbers of patients went home after their stroke, so long-term outcomes were similar. But again, it's 40 patients. And I think, I mean, the take-home point of that for me, and I think this is going to be a great discussion, is that it is an option. So it should not be taken off the table because someone is pregnant.
So a couple of things to keep in mind is that TPA does not cross the placenta. So the potential complications, people worry about effects on, the actual delivery, bleeding risk. And then in terms of the symptomatic intracranial hemorrhage, that was interesting too because they had higher rates. They had similar outcomes in that study despite having much worse strokes to begin with. So probably the reason they had more symptomatic intracranial hemorrhage is they had bigger strokes, which tells me that people are not giving it unless it's a really big stroke, where it seems like it's clearly going to outweigh. But I would argue that if those people actually had good outcomes, that even in a smaller stroke that's not such a clear-cut case like this, that it should definitely be considered. And the new guidelines that just came out from the American Stroke Association in January, they note that it's not an absolute contraindication and that they recommend it. They recommend the use of TPA in pregnant patients when the benefits clearly outweigh the risks, which is kind of a cop-out statement. But they don't say don't do it.
Right. But it does get, it gets complicated. So in this patient, she's first trimester. The bleeding risk isn't significant, but a decent number of pregnancies are occurring late third trimester, right around delivery, or maybe 2 days postpartum after a C-section. And so, some of those decision-making gets very, very difficult. I was just talking to one of our colleagues, Dr. Wira, that was called a code stroke, I think 3 days postpartum on a patient. And even thinking as he's running up to the code, would I even consider TPA in someone that may still be spotting after vaginal delivery or whatnot? Gets tricky.
I think this is really a key opportunity for shared decision making with the patient and or her family. We talk about this a lot with TPA, but this is really, this is the perfect case for shared decision making and explaining what we know, what we don't know. It is an option, but these are the risks, and having just a really thoughtful conversation, thoughtful but very difficult conversation.
It's also important to keep in mind that young patients, while they have better functional outcomes than older patients, they actually have a lot of disability after stroke. Even they have cognitive disability, they have depression, they have social anxiety, and they, this is a young person with a family with many years of work ahead of them. So even what we would think is maybe just a minor stroke is really not minor to that person. This is obviously a major stroke.
Excellent. Thanks, guys.
Yeah,
Sorry.
one more thing that I think we can bring up during this section is thrombectomy. So in our case, in this particular case, we didn't show you vessel imaging, but the particular case, the person did not have a large vessel occlusion. Is that right?
Correct. Yes.
But hypothetically, if there is a large vessel occlusion that you find on imaging, we're going forward with thrombectomy as we would with any other patient, and still considering the TPA in addition to the thrombectomy. I don't know if anyone else has comments on that, but.
I mean, the only other comment I would say on the thrombectomy is obviously there's going to be an additional potential risk of radiation exposure, although I think shielding in endovascular cases actually have some efficacy.
There's still like scatter. There's scatter radiation, but again, the benefit of thrombectomy in a large vessel occlusion greatly outweighs the very small risk. And for those extended window thrombectomies out to 24 hours, part of the reason it was a number needed to treat of 2 is that the outcomes were so bad in the people that didn't get it. And they had to stop both of those trials. They stopped Dawn first, and then they stopped Diffuse because of that.
Those are all excellent points. So with pertaining to this specific case, they had a very detailed conversation with the patient and ultimately decided to give the patient TPA. She also had a CTA, which did not show any large vessel occlusion. So the following slide is just a screenshot of one of her actual MRI. Eliza, I know this is not like screen through, but I don't know if there's any kind of interesting like radiographic pointers that you want to like point out to like the audience for us. I know it's hard.
So this looks like the ADC sequence. Is that right?
Yes, I believe so.
Yeah. So that's the one that goes with the DWI sequence. If it's bright on the DWI and then dark on the ADC, that indicates an acute infarct. This is left middle cerebral artery territory. It's interesting. It's sparing the deep structures. It looks like it's about a third of the territory, so pretty big stroke. So it's interesting that she did have a large vessel occlusion, and then it may have broken up and gone distally. Even with this size of stroke, I would be a little bit thinking about, is this person going to have swelling and edema? If it were bigger than this, especially if it were involving those deeper structures, I would definitely be thinking about that, and that's somebody that you would want to have on like a hemicranie watch for the next 3 or 4 days.
Which, I mean, as you mentioned that, it brought up a question that we were talking about earlier before the session about, well, if someone does have a large vessel occlusion like this patient, what about just taking the patient straight to thrombectomy instead of giving TPA, then thrombectomy? But this case actually highlights one of the problems with that is that she may have had a LVO that migrated, and if you don't give TPA, you're not giving any opportunity to clear that distal clot. By taking her straight to thrombectomy, you get there and there'd be nothing to clear.
Right, because they can't get that far in. So if it's not really proximal, they won't be able to get it.
I think that brings up the swelling. The mention of the potential edema following a stroke, like we're seeing here, also brings up a disposition point. So clearly, depending on where we're practicing, it might change. But it sounds like this patient needs the ICU. It's like at our shop, we do some stroke patients after TPA go to the stroke unit, which is kind of a step-down unit versus the ICU. But this is clearly someone who needs the ICU and or transfer to a comprehensive stroke center if you haven't already done that.
Yeah, if you have a neuro ICU, when we've had pregnant patients who are further along and closer to delivery, we've actually done deliveries in the neuro ICU. We've done C-sections in the neuro ICU. So, I mean, it can be done. And if they need the neuro ICU, it's better for them to be there and have the OBs come over than for them to be in like labor and delivery where they are not going to handle the neuro part so well.
Wow.
Well, in this case, she was transferred to a comprehensive stroke center. While there, she had a comprehensive workup that included an echocardiogram that showed likely patent for immunovolley, had negative Doppler ultrasounds, and her hypercoagulable workup panel was pending. She did have a 35 weeks spontaneous vaginal delivery. Post discharge from the hospital, she did have some persistent symptoms, but was functional at home, kind of like with her ADLs. So one of the last questions I have for the group is, in terms of approaching the secondary prevention strategies for stroke, are they similar to the same as any other individual, or are there any kind of unique things you think about with the pregnant patient? I mean, how do we kind of go about like the next steps, I think, beyond just like the emergency department in terms of how to tackle those things?
So one thing is, I mean, if she has a big PFO, she probably did have a clot. That's probably what happened, and I would be curious if they had done like an MRV of her pelvic veins, whether they would have found something in there. And to that point, I personally would put her, once she was out of the acute stroke period where you're worried about hemorrhagic conversion, I would put her on Lovenox, therapeutic Lovenox, for the rest of her pregnancy, and probably for the first, at least the first 6 weeks postpartum, and maybe up to 12 weeks postpartum, as your cousin was more than 12 weeks postpartum when that happened, and that hypercoagulability does continue. And then, then you can get into a discussion of whether her PFO should be closed, which is a whole other discussion, but you could definitely think about that. And then once she was not pregnant anymore, I would not continue her on anticoagulation indefinitely. I would put her on aspirin and talk about the PFO.
Okay. Great. So here's her follow-up CT scan. I don't know exactly how many months or how many weeks afterwards, but it shows like an expected evolution of a left MCA stroke, but no new acute findings and minimal mass effect. And basically kind of like consistent with some of the symptoms that she's been showing. So the last two slides I wanted to show you was similar to something that Tracy had brought up, to kind of like with these get with the guidelines data, talking about outcomes for individuals post TPA, both you're pregnant and non-pregnant. And you can see over here, it's a really small slide, I apologize. The slides, by the way, are on that app. You can upload it, so you have all the slides available that you guys can have. But you can see that it's a really small sample of individuals here, but essentially most of their outcomes are very similar to individuals who are not pregnant. So I think kind of like one of the take-home messages there is that while it's not kind of right now like something that is like FDA approved, it's kind of more off-label use, that it seems, at least preliminary with the data that we have, that the outcomes seem to be similar to other individuals who receive TPA. So that takes us to the end of the case-based session now. So we've got about 10 minutes left in this session. So I want to open this up to the audience to see if you guys have any questions right now.
I'll start with a question for my colleagues here. So now that there's been a trial published recently in the New England Journal showing that TNK may be, as efficacious or more efficacious than TPA, would you use TNK as similarly? Is there a risk to the crossing the placenta? Do we know?
I don't know the answer to that.
Do you know?
No, I don't know either. So
Yeah.
We don't know.
yeah.
I mean, that's a great question. And I'm very curious whether this is actually going to make it into practice or not. Whether like Genentech is going to let us make it into practice. But it's a great question. I don't know if it crosses the placenta. I think I would probably stick with TPA for now until there's maybe a little more data.
And Joe, do you just want to explain to the audience like what T and K is and differences with like that and TPA? Or?
Yeah, I mean the biggest advantage in TNK for emergency providers is it's a single push rather than a bolus and drip like TPA. So it's very convenient for for the ED management of stroke. And for a while that it wasn't clear if it was going to be equally efficacious, but then recent trial has shown equivalency.
And less expensive, right?
Yes.
Yeah, less expensive, and no more drip and ship. You can just push and ship.
And is anyone any questions right now? Oh.
I have two quick questions. So you sort of said the TPA doesn't cross the placenta, but is there any other like outcome data in terms of abortion or some kind of
There's nothing really out there, but there have been cases.
Repeat the question.
Oh, repeat the question. Oh, yeah, he was asking what about like placental abruption and placental problems like that, or fetal loss. I don't think that any of those cases had that in the Get With the Guidelines article, but there's really so little data out there about this, so we don't know.
Oh, yeah, sure. Yeah. Thanks so much. Yeah, there's 2 microphones right over there if you guys want to.
My other question was,
May not be on.
my other question was whether, historically they always use the TPA, well, almost always when they did thrombectomies, and like if you had a pending delivery in a pregnant woman, would you consider thrombectomy without TPA? I don't know if there's any sort of guidelines for that.
I don't like that approach because of what we were just talking about, that you can get to thrombectomy and there's nothing there to pull out because it's migrated, or they can't get up there because it's too technically difficult, or I've seen cases where it just didn't work, the thrombectomy, and so I would go with the TPA. But if there's really obstetric concerns in any case, I always involve the obstetrician in this kind of discussion, and getting them there can be very reassuring, actually, because I don't know what the complications will be. But generally, they're a lot less scared about the bleeding than we are.
Yeah, no, that's true. They usually are. And I think, yeah, I mean, the thing to keep in mind, too, though, is if the risk of bleeding is significant and the obstetricians are worried, then, yeah, that would be a case that it probably would be best to go to thrombectomy without TPA. But for most cases where bleeding is not a huge issue, I certainly agree that I would still give TPA, then look at thrombectomy.
I think that's an important point for many of these cases, that we are going to be involving obviously the neurologists and then the obstetricians, especially if this is a viable fetus.
Any other questions in the audience? Great. Well, I'd like to give a round of applause to our expert panel here. Really.